Welcome, everybody. We're so glad you're here for today's 1-hour session on building successful survivorship programs of any size. It's going to be a conversation with experts here, and I'm really pleased we've got such a great group. Lots of different organizations represented here, so we're really excited about that. My name is Julie Taylor, and I work with the survivorship programs at Children's Cancer Cause. And I want to take just a minute to give you a little background. Children's Cancer Cause mission is to champion policies and programs that improve the lives of pediatric cancer patients and survivors. And our core goals are to accelerate the development of and access to safe and effective therapies for children with cancer, and to improve the quality and accessibility of long-term follow-up care to improve the long-term health for every survivor. So that's where this comes in. And as part of our focus on survivorship, we created several years ago the Survivorship Champions Prize. And this prize awards funds annually to survivorship programs that are making advances in programs and services to address the lifelong health maintenance for survivors. And as a way to leverage the collective expertise of the Champions Prize winners, we created 3 years ago the Champions Prize group. And this is a forum to share knowledge among these recipients and their best practices. And today's meeting is really a direct result of the work of the prize group. And today's moderator, Katie Devine, will share a few more details on the work she has done that she has led to get us to today's event, and some of the other things that she's been critical in doing to sort of, again, raise awareness about survivorship and survivorship programs. And we also have, so among the speakers today, and they will introduce themselves as they speak, but we have a few past recipients of the prize who are members of the prize group, as well as a member of our Survivorship Advisory Council. So with that, I will turn it over to Katie.
Thank you, Julie, and thank you to Children's Cancer Cause for hosting this webinar today. Welcome, everyone. It's my pleasure to help moderate this session. As Julie mentioned, the Champions Prize group winners have been working together over the last year or so, trying to think about ways to leverage the expertise of this group of leaders in survivorship care, and how we can help give some of the expertise they've gained over these years, and really spread that knowledge to other programs who are trying to build or enhance their own services. So in that spirit, in the last year or so, we've been working to try to get this information out on the website. The Children's Cancer Cause has a website related to the Champions Prize winners, and talks about in each profiles the programs and why they were selected as a prize winner, kind of highlighting some of the really outstanding work or innovative work that they're doing. And in just the last few months, we've actually had a series of video posts come out where we asked each of the leadership from each of the programs to share a little bit about what advice they would have for a new program wanting to build. And really the goal is to help new folks who are trying to build a program, or even those who have a program started and want to think about expanding their services, or or ways to sustain programs long term. So I hope that you'll check out this resource. And then today's webinar is really an effort to, again, engage with experts, and also just start a discussion amongst those working in this field, and hopefully have a really great, rich discussion at the end to talk about challenges you've experienced, as well as successes and questions you have for our experts. So I'm delighted to turn the program over to them. In the spirit of really thinking about survivorship really starts with our survivors. We're going to start our talk today with a survivor, and then we have 3 experts who are the directors of their long-term survivorship programs, who are going to share some of their successes and challenges along the way. And we hope to have at least 20 minutes for discussion at the end. So please do jot down your questions in the chat, or we'll also have some questions that you sent us in ahead of time. So it's my pleasure to now turn this over to Megan Kilner, who's going to share her experience. Thank you, Megan.
Thanks, Katie. So hi everyone. My name is Megan Kilner. I'm a Hodgkin lymphoma survivor, 24 years old, and I've been in remission for 8 years. And today I'll be talking to you a little bit about my perspective on survivorship. So you can advance to the next slide. So just for a quick outline, I'll be talking a little bit about my story, then about the challenges, successes, and areas for improvement in early survivorship and later survivorship phases in my experience. So just from a little bit about my story, I was diagnosed with Hodgkin lymphoma when I was 15 years old. I went through 6 months of standard chemo and radiation, had a relapse when I was 16, and was in treatment for about another year with immunotherapy, stem cell transplant, and maintenance chemo. By the end of treatment, I really felt like a different person than I was at the beginning. I was dealing a lot with fatigue, pretty serious peripheral neuropathy, and also just post-traumatic stress. I didn't know where to go from there. You can advance to the next slide. So just talking a little bit about early survivorship, some of the challenges were trying to address numerous treatment-related problems, both physically, emotionally, even logistically, transitioning back into school and normal life. And I was also transitioning to college in the midst of the pandemic, which added a lot of complications. Um, so some of the things that worked really well for me at that time were coordinating care around my goals. So I was able to see a physical medicine and rehabilitation doctor, and she helped me a lot with coordinating physical therapy, using ankle and foot orthotics, and getting those while the neuropathy was still resolving. And beyond that, making goals for myself for survivorship and applying for accommodations in college, which helped me to be able to keep up with my peers. Another thing that helped was getting expectation setting about what I could expect to improve and the rate of improvement. I think I had an idea in my head that, in 6 months or a year or 2 years, I should feel normal again. And if I wasn't meeting that, then something was going wrong. But understanding from peers and from survivorship clinic that recovery takes time and it might not look the way that I expect it to, but that doesn't mean that it's not getting there. Some of the things that didn't work super well were just having some misalignment on goals with my oncology and survivorship team. Of course, the team was appropriately concerned about issues like relapse and cardiac toxicities, but at times that felt like it hit up against my day-to-day concerns about quality of life, and I didn't always feel heard in that way, and that can be challenging to balance. And as a result, I was seeing many different specialists again to focus on those big concerns. And that took me away from school, away from sports and activities. And in some ways, while very necessary, could also hinder my recovery. So now we'll talk a little bit about later survivorship. So some of the challenges that I've faced in the past years and even now are the continued cost, time, and mental burden of extensive follow-up in the midst of a busy life. I think when you are diagnosed with cancer, everything gets to be put on hold for a little bit, but I still now am a medical student. I still need to do everything else that my peers need to do and then have follow-up on top of that. And another thing is realizing the new normal and nonlinear improvement. Some of the things that have worked really well is the integration of my primary care with survivorship clinic at the hospital where I was treated. This allowed me to consolidate some of the long-term follow-up testing and really only see specialists for active problems, while my primary care, who understands the guidelines, can follow up on tests that are stable and make sure that I'm getting everything in that I need to be followed, but not more than that. Another thing that's helped is my own personal increasing health literacy. I think that can give people a lot of power to understand why it's important to continue with follow-up, even when it feels really like a burden. Something else is using imperfect but accessible resources. So when I was in college, it was hard to see a particular physical therapist for who might have had experience in peripheral neuropathy, or to see a therapist who might have had experience in cancer survivors. But even just using the general resources at my college was actually more helpful in many ways because it got me integrated with my peers and able to use exercise resources, use therapy resources that were right there. And that it's hard to overstate how much of an impact that had on me, just having that integrated in my day-to-day life. Finally, I've been able to define my goals and values and move some of those post-traumatic stress to post-traumatic growth. And I think even brief conversations at survivorship follow-ups about what's going well can really help people to reframe in that way. One thing that still is a challenge is, again, the time burden of follow-up and following guidelines, and also the time and cost of fertility preservation, which I've been going through. Pretty much all of my school breaks are taken up by going to appointments, getting tests done, and doing cycles of egg freezing. So that's something that's really challenging for survivors, and I know not so easily addressed. But kind of to sum it up, I think if we can support survivors to understand the importance of long-term follow-up so we can stick through it when it's hard, but also doing anything you can to consolidate those resources, help find resources that are accessible, that makes a big difference. So thank you.
Really appreciate you commenting on both what's gone well and what's still a challenge even now. Next up, we have Dr. Rusha Bhandari.
Yes. Hi, everyone. And Megan, just to echo, thank you so much for sharing your experience. It's so valuable to hear that and to understand, what's working, what's not, and what we can continue to do to improve our care. So I'm Rusha Bhandari, and I'm an assistant professor in departments of pediatrics and population sciences at City of Hope Comprehensive Cancer Center, which is in the Los Angeles area. So today I'll be giving a brief overview of our clinic and focus on some of the efforts that we've made to try and meet the needs of our growing AYA population and some of our infrastructure changes to try and enhance our program operations and patient tracking. So go to the next slide. So this is our survivorship team. We do have an interdisciplinary team with expertise in oncology, nursing, psychology, nutrition, and then program administration. We also have well-established relationships with other subspecialists that our patients often need to see as well, such as neuropsychology, cardiology, and endocrinology, just to name a few of the more common ones. But obviously, are well established with different providers throughout City of Hope. Go ahead to the next slide, please. So about our clinical program, it's open to survivors who were diagnosed as a child or as a young adult with diagnosis before the age of 40. And so that was an effort that we had made in recent years to really expand to the AYA age group, recognizing sort of a gap in that area. For the young adults to be eligible for our program, they would need to have had a childhood-like diagnosis. So for example, leukemia, lymphoma, sarcoma, diagnoses such as that. Patients need to be in remission and off treatment for 2 years to be seen in the clinic. And then importantly for us, there's no upper age limit for our clinic. So we're happy to see patients for as long as they're happy to come back and see us. And we certainly have patients who are in their 70s or even older who have been with our program since it started. And we're just thrilled to have the opportunity to continue following them. We receive new patients through a number of modalities. We do receive new patient referrals internally. We have a specific referral order for our clinic in Epic. We also periodically present program updates to both pediatric and adult providers, and they are really good about referring patients over when they're eligible, or just sending us a quick note of, oh, hey, this is our patient, this is their situation, are they eligible? We're always happy to field any of those questions. We also conduct sort of internal queries to identify potentially eligible patients. And then again, since there's no aging out from our program, we often receive referrals from other pediatric programs in the region once patients can no longer be seen there due to age. And then, as Megan mentioned, the AYH time is a time of transition with school and work. And so we also receive referrals when people relocate, geographically, or have self-referrals if they hear about us through friends or social media. Patients also have the opportunity to opt into research aspects of the program. So it initially would involve optional blood collection and questionnaires, but it also serves as a platform to identify potential participants for other survivorship-focused studies that we have. And I have to say we're incredibly fortunate to have a very engaged patient population that's excited about research and continuing to contribute to this field. So we're just so lucky to have such a wonderful patient population that we work with. And in terms of location, currently our clinic is open at our main Doherty campus, which again is in the Los Angeles area. And we do make every effort to accommodate patients via telehealth if it's appropriate for them. And we have strategies in place to identify, patients for whom that would be appropriate. Go to the next slide. So one change that we've made in recent years is to increase how we leverage digital platforms. So since our clinic started, all patients receive a personalized binder with their personalized treatment summary, which is developed by our team nurses and APPs, as well as summary recommendations, which you see on the right-hand side there. All of this information is uploaded to their online portal for ease of access and sharing with their other healthcare providers. And while they still receive this paper treatment summary and the binder and the summary recommendation that you see here on this screen, we've worked with the long-term follow-up guidelines team to also add QR codes to the relevant COG health links in our sort of summary recommendations there on the right, so that information is more readily accessible in a digital format. We can go to the next slide. We've also focused a lot on our online educational materials. And so on the left-hand side, you can see we have AYA patient stories detailing their journeys and the importance of survivorship care, and that's in both English and Spanish. And actually the top video is from someone who's now a nurse practitioner for our clinic. So really lovely videos of patients sharing their stories. And then as shown on the right-hand side, we've also developed our own brief videos on high-yield survivorship topics. And these videos were created by our own team members. So the hope is that patients see, friendly faces while watching the videos. If I'm seeing them in clinic, I'll say, hey, I made this video. I'm going to send it to you right now. They're available on our website, but it's also integrated into Epic. And so we can send it via their online portals through a digital care tab that we have. And that's been a really helpful way for us to get this information to them digitally, and hoping it's something that they'll, pull up and watch while they're in a waiting room or scrolling for a couple of minutes. We've tried to keep them, brief and digestible. So next I'm going to pivot to our infrastructure. Our program was established over 20 years ago, and as such has gone through, many different databases to keep track of patient clinical workflows and research data collection. As anything, there's pros and cons to all of the different databases that we've used. But we recognized a few years ago that as we grew our program, we needed something that was more cohesive and also easily accessible by all team members, because we were growing not only our patient population, but also the team. And so this is actually something that we were able to do with the support of the Children's Cancer Cause Champions Prize. And we developed a new database using Microsoft Power Apps. And so over these next few slides, I'll sort of show you how we utilize this functionality in our clinic. And so first, this platform can pull in basic demographic and contact information from Epic for patients who may qualify for the clinic or for whom a referral was placed, so kind of automates that process. This next is our screening tab. And so, we can go back, Julie. Yeah, so our team can then go in and enter details regarding patients' cancer and treatment history to then confirm if they are eligible based on that information for the program. And we also have the opportunity, there's at the top left, it says NRD, and that stands for next review date. So if someone maybe isn't eligible now, but can be in the future, we can, set a time for example, 6 months from now to remind us to, hey, re-review, the patient may now be eligible for the program. We can go to the next slide. We then have a recruitment tab to track when and how we've contacted patients about the clinic. If they're interested in participating in that research component I mentioned, this tab allows us to track that consent process. Next slide. And then one of the unique aspects that everyone here knows about a survivorship clinic is a lot of that upfront work that we do before we have a patient come to clinic to make sure we are informed and prepared. And then a unique aspect of the clinic, of course, is the treatment summary. So here we track, whether we have outside records, if applicable, if they were referred from a different institution, which team member is working on the treatment summary, if it's been completed, and whether the relevant appointments have been scheduled, because of course we try and get all of the screening diagnostics, combined into one day if we can, just to make things as convenient as possible. And then we can go to the next slide. This is our clinic summary tab. So it keeps track of whether patients completed their visit or rescheduled, who their survivorship provider was. We go back afterwards and enter any additional lead effects into Passport for Care that we learned about during the visit. And I would say tracking these metrics has actually been really helpful in adjusting our workflows. So for example, we used to schedule visits a year out, like other, appointments that you make with your providers. But we noticed that we were getting a lot of reschedules because things change. You don't always know your schedule for next year. And so we now set those review dates and contact patients maybe 3 to 6 months before they're due to come back. And so we'll see if, hopefully that helps from the scheduling aspect. So it's integrated into both our research and clinical workflows. And then we can go to the next slide. I would say a key component of our continued patient engagement is partnership with our really amazing AYA program. I really can't say enough about the great work that they're doing. Some of the highlights of the program include things that are listed here. And so fertility navigation, financial support, whether there are mechanisms we have internally or resources that we can, direct patients to. There are peer support activities, both on campus and off-site, so kind of something for everybody. There's very pointed educational and vocational navigation, right? Because we know that these are critical times and people are having to reintegrate into school and the workforce, and there's still a lot of support that they provide there. And then they also have peer focus groups and a couples program. And so I really think this, enhances the services that we're able to provide patients with because we complement each other's efforts and are hopefully able to address more holistically their needs between our survivorship program and our AYA program together. And then yeah, that brings me to the end of my presentation. Again, I really appreciate the invitation to present today, and I'm happy to take any questions afterwards, or feel free to send us an email or snap that QR code and send us a message anytime.
Thank you, Rusha. You really have a lot of excellent services, so thanks so much for sharing them with us today. Next up, we have Dr. Pinky Prasad.
Good afternoon, everybody. Thank you guys for having me. Thank you, Megan, for your powerful testimonial. I think it's really important for us to know what our survivors need. So a little bit about myself. I am a professor at LSU Healthcare System in New Orleans. And so our treatment after cancer-related effects program is called TACKLE. And it was started by myself about 14 years ago. Next slide. So our program overview, we actually take care of patients who have completed cancer treatment, and similar to Rusha's program, we take care of any patients that are more than 2 years off therapy. Our goal is to focus on monitoring, managing, and mitigating long-term and late effects. We have a very dedicated clinical team that includes myself as an oncologist. I have 2 advanced practice providers that help me see patients, actually help with treatment summaries. We have an education specialist who is a person who is through our human development office at our School of Medicine, who actually helps our patients reintegrate into school and helps with scholarship opportunities and things of that sort. We have a psychologist who sees every one of our patients in clinic and helps with any kind of emotional needs, helps with sleep therapy, and helps refer if they need any help. An endocrinologist, a cardiologist, and we have navigators who help us schedule all of our appointments. Similar to other programs, we try to get as many things done in one visit if we can, and if we can't, we try to refer out. We do lots of late effects monitoring, which includes surveillance for all the regular disease statuses, but also for cardiac, pulmonary, endocrine, cognitive issues. We really do believe in a holistic wellness focus. We integrate mental health, nutrition, and physical rehab if possible. And we always try to discuss fertility at every visit. Our goal is to coordinate transition from active treatment back to primary care. And so we have a number of different primary care physicians that we are in close contact with. But if a family member lives many hours away, we really try to get that primary care provider integrated by myself having a telehealth visit with just the provider to try to teach them any issues that may have. Next slide. So our eligibility criteria, like I mentioned, you have to be off therapy for 2 years, no evidence of active or recurrent disease. You can still be on surveillance or maintenance medicines if needed. We do provide a treatment summary, very similar to Rusha's program. We do use Passport for Care. So all of our providers are provided a treatment summary at when they first come to clinic, including a binder with all the health links. And then every time they come see us, we do repeat and just give them a copy of their survivorship care plan. Our age setting, we're able to see patients. I'm at a children's hospital, so we see patients all the way up to 25. And we do now have a AYA partnership where we are able to see patients up to age of 39 at an outside clinic along with our adult oncologists. You can be referred by a treating oncologist, or we also accept soft referrals as well. And in terms of clinical need, we do want to make sure that we are discussing any experiencing late effects. And so prior to our patients coming in clinic, they do fill out a summary that's integrated into our EPIC system, which is our EHR. And we're able to look over that summary prior to these patients coming to our clinic. And so we can discuss what things that they're wanting to discuss at that visit. We don't really have any exclusions right now, except for hospice and palliative care only goals. We are trying to integrate that into our system as well. And we accept from all types of catchment areas. So you don't have to live in the state of Louisiana to be seen by us. Next slide. So what are the patient materials and resources we use? Like I discussed, we use a survivorship care plan using Passport for Care. We do have a late effects education packet that our education specialist actually does. It's a quick, a little survey that they do in clinic. Part of our award that we received from the CCC, we actually bought iPads that actually have all our surveys integrated onto them. And those surveys are then given to patients in clinic so they're able to fill them out before they leave. And we have an education specialist who actually helps with that. We do a follow-up appointment guide that actually schedules out their visits. And we do currently schedule patients for up to a year out and includes all the lab work and imaging calendars that they have. Also discusses how to prepare for appointments. Our social worker who sees our patients works with insurance and authorization resources as well. We have been starting to work with a lot of our community providers. And so we do provide a cancer support group at least once a month for all of our adolescent young adult cancer survivors. And we also have a separate group for our pediatric survivors as well. And one of our big things is, like I said, it is really holistic wellness. And so we provide nutrition guidelines post-treatment. We do have a registered dietitian who is able to see our patients if they are wanting to see them. And we provide physical activity recommendations. We do have a smoking cessation program that we provide for any of our patients who are smokers. And we discuss fertility and sexual health and have a REI that is available on call, meaning that he will be able to do telehealth visits if anybody wants a visit at that time. Our newest thing is we do have an annual wellness newsletter. So we do provide a survivor success stories, upcoming events and webinars, and if there's any changes to treatment and screening guidelines. Next slide. Similar to many other programs, we really do feel like that research is a really big part of survivorship. So we do have a database and patient engagement platform that we use. All of our data is captured through Epic, and we have a data capture system that actually then dumps all of our data into a REDCap database that allows us to examine the data as needed. A lot of our data is through PROS, which is patient-reported outcomes, and that are collected at each visit. We do a very large questionnaire in the very beginning at their first visit, and then annually we do separate questionnaires. And this allows us to do longitudinal tracking of labs, imaging, specialist notes, and any other issues that they may be having. There is a structured data field for AYA program crossover. So if our patients are going to their primary care, and if they have EHRs, then we're able to cross those patients over. If not, we make sure that all the data is given to the patients via a QR code. So they're able to, our PCPs are able to use that data. We also use a lot of automated features. We do My Chart and text message alerts for labs, imaging, and annual visits. We're very big about secure messaging through our EHR system, including telehealth visits. And this allows us to communicate with our survivors outside of them having to come see us in clinic. Next slide. Like I mentioned, our AYA program partnership is really, really important. We do partner with our adult oncology colleagues that are located at a hospital about 8 miles away. We do a off-site neutral ground clinic is what we call it for transition. So it's actually at a big primary care facility where our adult oncologist, our pediatric oncologist, and a primary care provider is able to meet new survivors who are past the 25 years of age and who want to transition to be outside of our system. I think this is really important for a lot of different reasons, and I think Megan touched on a lot of these. We know that there's a high risk of being lost to follow-up once you aged out of a system, especially if you aged out of a children's hospital. We want to make sure that we are addressing that and we're addressing life transitions as they happen. We also understand as patients get older, there's complex insurance and social challenges, and we want to make sure that we're addressing those navigation issues. And mental health issues are a large part of what we see, especially in New Orleans. And so depression, anxiety, PTSD really disproportionately affect our AYA population and want to make sure that they are being addressed as well. We really believe early intervention equals better long-term outcomes. And so that is our big motto for our transition clinic. Currently, our shared program activities include a few things. One is a co-enrollment pathway that we've started offering to all of our adolescent and adults. And so they're offered at the time they enroll to my clinic, but it allows us to also very quickly try to find a PCP for them if they don't have one. We do have a joint tumor board that's actually just for survivorship. And so usually tumor boards are allocated for new diagnoses, but we actually do a tumor board just for survivorship planning for all of our AYA patients that are transitioning. And we do have EMR flags that will flag somebody who is a cancer survivor. So if they go to an emergency room or a new primary care provider and they have the EHR system, people are able to see that they are a cancer survivor very quickly. I think things we're working on, one is a peer navigation tool where some of our survivors who have graduated from our program and are wanting to stay connected can become navigators for our future patients. And then doing some more education events with our AYA and our tackle survivors. We have workshops, webinars, and support groups. Next slide. And so I think this is just a couple of things that just like a quick reminder. We do see patients 2 years plus post-treatment. Currently, we are seeing up to 25 in our clinic, but up to 39 in our transition clinic. And really our goal is a 360-degree whole patient approach. And so I'm happy to answer any questions at the end of this and look forward to the discussion.
Thank you, Pinky. We really appreciate all the excellent work you're doing, especially with the AYAs you highlighted at the end. Next up, our final speaker for today will be Dawn Carey.
Thank you. My name is Dawn Carey. I'm the pediatric nurse practitioner at the Cancer Institute in New Jersey. We work with Robert Johnson Barnabas Medical Health. I am the director of the Light program. I started it about 25 years ago, and we've been going strong. So it's a very exciting time. Thank you, Megan, for sharing your story. It's always great to hear from survivors. We love it. So our program is called the Light program. It started with just the vision of a lighthouse, which basically is a beacon of hope. It shines to the future, gives a bright path. So it means long-term information, treatment effects, and evaluation. Next. We don't have any financial disclosures, no relationships to disclose either. Next. So our Delate team started really with myself 25 years ago, and we brought on a physician. So our next addition was our nutritionist, social worker, and nurses. We do very well with that group, but we thought we had to branch out and add some other specialists on. The psychologist, our research team, Katie Devine, and population science have been a great addition. And new additions, cardio-oncology has recently joined, and we have a primary care physician who is interested in survivorship as well as primary care. So that is a new addition to our team. Next. Our goals of the Light program is to provide cancer survivors with the best quality of care while addressing their individual late effects, providing them with comprehensive evaluation, and just as other programs, providing education, support, interventions, and referrals to subspecialties. We give them a comprehensive treatment summary as well as recommendations for follow-up. We also do use the Passport for Care, and we do have the EPIC system that we use as well. We offer educational programs and support groups for our survivors, and we serve as consultants, and we do research projects to help improve patient care. Next. Our program participation is any survivor who is treated for childhood cancer is 2 years off treatment and no evidence of active disease. They've recovered from any acute complications from therapy, and they can continue in our program for a minimum of 10 years post-treatment, and we will transition them to adult care somewhere between the age of 30 to 35 if they continue in our program. Next. Pediatric survivorship. Long-term survivorship, it's an expected outcome for most cancer patients, and our goal is to provide them with the best quality of life, as Megan said, which is very important to them. We know that there's about 20,000 children diagnosed every year with cancer, and our cure rate is at least 80%. Some diseases have a much higher percentage of cure, and we are very happy with that success. Yet, we do know that many of our survivors struggle with chronic health problems. 25% will have a severe or lethal chronic condition, and 25% will have 3 or more chronic health problems. So what does this mean? We must do better. We must improve survivorship and give them the best quality of life. Building survivorship clinics, how do we do it? Our multidisciplinary team is the base of our program. And as everybody said, and most people have similar members to their team, a nurse practitioner, pediatric oncologist, a nurse social worker, dietitian, psychologist, and research team, as well as our new additions that we just added on to our program. Next. Tips for getting started is spending time getting buy-in from all the interested parties. From an oncologist, we utilize resources that already exist. So we have our oncologist who also sees other patients. She sees active treatment as well as I do. And we also run the survivorship. Include patients in the planning, find what they want. What are their goals? What do they think they need for survivorship? Access and use any existing services that are already out there. Figure out that what might work in your particular setting, because every institution is different. Some programs, I get very jealous when I see people have like 35 different members of their group, and there's just a handful of us, but we're strong and mighty even though we're small. Understand that you'll need to implement, access, and revise your program, and don't get discouraged because things change and you can always make adjustments. Some challenges that we've faced with is a fragmented care system. We do not have everything under one roof. We have it within our system, but we have the patients come see myself and a physician. Our psychologist is here, our nurses, and our nutritionists and our social workers. But as for cardiology, endocrinology, they are in other buildings, and therefore they have to do appointments at a different time. Lack of training and education about survivorship issues, the lack of awareness of late effects and how to treat those late effects, lack of insurance coverage for services. There's also limited support for survivorship clinics, and patients often get lost to follow-up. And there's a transition issue with adult care challenges that exist out there, just trying to transition the patients. Next. Our light program and research, one of our prize that we've with our champion prize, and also with something we're very proud of, is we work very closely with our population science at the Cancer Institute. We've done multiple studies to help improve patient care and to learn from our patients. They give us a wealth of knowledge and provide us with a lot of things that we can change within our program, and things that we think we're doing very well. Sometimes they don't remember. It's a lot of information. It's a lot of stuff. I know I teach sun safety all the time, and with our study, nobody remembered sun safety. But we have a sun safety program study that we did, an exercise program and app, a managing your health app and module, a mentorship program, and our new ones that are a work in progress is a primary care transition program, as well as developing and implementing a fertility preservation program. So those are both works in progress. Next. This was one of our studies that was from our needs survey, and basically what we looked at was, did patients have primary care physicians as adult survivors? And they did. They had primary cares. We learned that 25% of them don't think that they think that our doctors talk to their doctors and communicate well, but that leaves about 80% that either aren't sure or they don't think their doctors, their primary care doctors, are in contact with us. So we felt like we were failing in that aspect. And how do we improve that? We asked some questions about, did you feel like your needs were met? Did you feel like your doctor talked about monitoring your late effects? Did you feel that they followed up on tests or knew what tests to order for you? And what we found is that they really didn't. Next slide. So within the study, we had 123 adult survivors participate. 75% of them had a PCP, and more than half of their PCP's discussion survivorship topics said that they did not discuss it at all, or it was very little. So that's where we came about with the transition program of having a PCP and helping to bridge that survivorship gap. So we have a primary care physician who is interested in survivorship. He joined our group. He comes to our meetings, which we hold every 2 weeks. We transition any survivor who currently does not have a primary care doctor and can get up to our hospital because he is is across the street in New Brunswick. So they have to be able to get up here and be within the area. And that's one challenge we have too. But we'll transition. And he therefore joins our meetings. We can discuss what he finds at his visits and what we find at our visits and put it together and develop a joint plan for this particular patient. So this is going to help bridge some of our gaps that we found through that study. Next. And some of the lessons we learned is that we need to build a strong medical community. We need to utilize existing resources, talk to people that have started programs in other areas, look for financial support, even if it's small grants. We do this very often. We try and find little grants and piece them together so that we can build on our program, build a survivorship community, and then provide education and support opportunities for survivors. This is one of our education nights that's coming up. We do it annually every year in June or September, depending on how busy we are. And survivors and their families are invited. We have guest speakers, and this year we're doing a panel of experts so that the survivors can ask any questions that they have in regards to survivorship to our experts. Next. And this is our backbone to our survivorship program. We use the Children's Oncology Group long-term follow-up guidelines. It's available for everybody to look at and use. It gives you, based on treatments that patients receive, what follow-up care they need. And that's the basis for our program. Thank you very much for listening, and we will take questions shortly.
Thank you, Dawn, and thank you so much for touching on the length and sustainability of the program and how you've built new things over time. I'm going to start us off with our questions. One of the questions that came in is very related to what you were just presenting. Many people wrote a question in about how do you start building when you're at a smaller center and think about ways to sustain financially over time. So I'll open it up to whichever the speaker wants to try to tackle that first. We can hear from each of you.
I'm happy to start. So we're actually a very small program as well. And so, New Orleans is a very under-resourced center. And I started with just myself. It was just me as an oncologist. I still see on-therapy patients. But this was always a passion of mine. I started, seeing survivors when I was a fellow. So it literally, my initial clinics were once a month, and I would see anybody who was 5 years off therapy, and just started with myself. And then I started getting buy-in really from, it started small with my division chief, and then slowly through small grants, like Dawn and Risha have mentioned, was able to build a program that's a little bit larger now. And it took about 14 years to kind of get everybody on board, but it really started very small. I was lucky that when I decided to do my program, Passport for Care was one of the first things. I had actually gone to a conference and they started mentioning Passport for Care. So I started using that from the day one, and that's where all my treatment summaries were based. But I think if you are really interested, I don't think you need a massive team to start. I think just 1 to 2 people that are interested is more than enough to get started. And I think once you start building momentum, more people will follow.
I have to agree. I think that, it started as myself. I actually, before the Children's Oncology guidelines came out, I was handwriting them and trying to create them myself. So when they came out, that was a miracle in itself. And then I started with a large, gigantic binder of instruction sheets that went out to everybody with a book that I hand wrote their treatment summary in. So I think it's definitely doable, even if you start on paper and pencil. And then there's so many advances now that can help you and assist you to branch out. But if you get support from, even one person, it was our chief. He really focused on survivorship, wanted us to build something. And I came to him with this vision, and he was my backbone. So because I had a good support, we were able to get more members to our team.
I think everyone already said all of the things I would want to. And so I think it's a good sign that we all would agree on this. I think, our program was started well before I joined our institution, but similarly, it's a small core group of invested individuals that recognize this need and this gap who start the program. And even in my time here, it was still a pretty small core group, and then we've slowly grown over time. So I do think, like you both just said, if you build it, it will come, and the interest will come with it.
Thank you all.
And you have to realize that there's no one set way to do this, that you can utilize what resources you have available to you at that time, and you can kind of build it that way.
Yeah, great point. And I think all of you mentioned different resources that you leverage that already existed at your institution and pulled them in. And so that seems like a great strategy.
And Katie, I'll just add, at the end of today's meeting, we will send out in the chat several links. One is the resource center that we showed you earlier today, because that does have information from each of the Champions Prize group members. And they do a little video and talk about their programs. There's also contact information there for you to reach out to people individually. We also, there is a group called CAC2, the Coalition Against Childhood Cancer, that has put together a survivorship toolkit that is geared primarily to the survivors and families. But they've got over 1,000 resources in this database that I think can be helpful to people too. Things that, you know, they've spent a lot of time collecting these resources, and they're available through that toolkit. So we'll make sure you have that link as well.
Thank you, Julie. I'd like to open up the floor to anyone with a question. Please feel free to type it in the chat or raise your hand. Or just unmute if you can't find the raise your hand button. Oh, Angela, go ahead.
Yeah. Hi, everybody. Thank you for these great presentations. It is really interesting to hear from different institutions and how these programs have been developed and what you offer. And I actually have two questions. So one for Dr. Bandari, real quick. I was really impressed to see the pictures you showed of the events you host for the survivors and how big they are. And I was wondering, since I think you said you're in the LA area, there's a lot of Spanish speaking folks, so do you offer your events in bilingually? Do you offer bilingual materials, or do you have interpreters? I'm just curious how you approach all of your survivors and their families.
Yes, it's such an important aspect of care to make sure we're doing our best to provide culturally concordant care for all of our patients. I cannot take credit for those events I showed at the end. That is our amazing AYA program that I'm just fortunate to partner with, but we do work very closely with them. And so I can say from the survivorship clinic standpoint, some of our team members are Spanish speaking, and so that is definitely helpful in the communication in terms of when we're calling, scheduling, engaging, and then of course in clinic, if we don't have a team member who speaks Spanish or any other language, then we have different interpreter services. On the AYA program side, yes, many of the specialists within the AYA program are fluent Spanish speakers, and so they are able, I think, to bridge that gap and host the events or even smaller group sessions in ways that work for different patients and meet their needs.
That's great. Thank you. And may I ask the second question? Megan, thank you so much for sharing your experiences. And so I'm at Rutgers Cancer Institute with Dr. Devine and Dawn. And from Dawn's presentation, maybe you recall that we're in the process of building a fertility program. And I was very struck by what you mentioned on how you have to go about getting the egg freezing done and how many appointments it is and how it takes away time from other things. And I was just curious if you had some message, recommendation, or suggestion what flourishing or a program that's being developed, what we should watch out for or be mindful of as we're building this, anything that would have helped you or that you would have liked to see.
Yeah, I think one of the challenges is can be like deciding whether to go to a provider that's closer to me versus one that's more integrated with the health system. So when I initially did a cycle of egg freezing before my bone marrow transplant, that was up at my the hospital I went to, which was over an hour from my house. But they had really good resources for me as a survivor, could help me get connected to grants, and that was helpful. But now I've made a decision to do the cycles closer to my house at a clinic, but that's been really difficult to integrate, like the people at the clinic not necessarily understanding a lot about AYA cancer survivorship. So I think that's a gap area, is maybe in a similar way, some of the speakers have talked about doing quick telehealth education with providers. So even if survivors can't go to somebody who's really well integrated with your program and REI there, being able to send them along with educational materials for their REI, I think could be helpful.
Great. Thank you.
Thank you, Megan. I really love that suggestion. There's a question in the chat I'll read out loud. What kind of grants would be good to apply to for financial support? We have a small survivorship program at a community hospital. Has anyone had experience?
Yeah, I don't have a specific answer, but I think, for instance, the survivorship toolkit, they have a lot of, they have one of their categories is on financial support. And I'm assuming most of that is directed to individuals for, coverage of care and things like that. But I have a feeling there's a lot in there about available grants for institutions. But it's a challenging world out there when it comes to this. But that'd be one place I'd recommend you check. And there are a lot of larger corporate sponsors that offer things like this. They might not necessarily state that they are cancer specific or pediatric cancer specific, but you can apply for support for programs that you have that that they would find worthy.
Yeah, I don't have anything specific either. We kind of just search the web and see if anything kind of matches what we're looking to do at the time. But I think different states sometimes have, for startup programs, you can often look, it may be cancer related, it may not, it may just be within the medical field. You can look there. Some of the drug companies too will also sponsor or support. I know our last donation was just from a high school in the local area who wanted to do a fundraiser and raise $10,000 for us, and they picked us. So using something like that, they did a softball game, and all the funds went to us. So we kind of just keep searching and try and take what small little grants we can get that we find. I'm not sure if that's great news, or helpful, but grants are very hard to come find at this point in time. But yeah, you can search, and sometimes there's little startups or little organizations that will help support it just to get you started.
I think we did something similar. I think that, for me, when I started this clinic, I actually had a business proposal. And so I actually took this more through the hospital and our School of Medicine and made it into, this is a very big need, and we will actually be generating RVUs, and we're going to be generating revenue. And that was really the avenue that I took first, just because the grants in Louisiana, especially, there aren't that many that are like localized. And so that was a big push for me. Like when I was able to do a business proposal and get in front of the administration, they understood the need. And I think that was what really, that's how they actually initially funded some of my time to do this. And in the interim, since then, I've been able to do, just like Dawn mentioned, get some small grants through like Pfizer and Novartis for tiny little things. But then just, and none of these grants are very big. They're $5,000, $10,000. And a lot of people will be really, quote unquote, donating their time. And the way like we have, actually rationalized this with our hospital system is they are seeing patients and generating RVUs and generating revenue, and there's downstream revenue. So I think the mechanism is going to have to be twofold. I think if your center is willing to buy into this concept, I think a business proposal and really kind of showing them what the value is going to be important, because grant funding is so finicky, and especially for what we do, it's very limited.
Thank you. And then, yeah, I agree. The business proposal sounds like a great opportunity to convince leadership to get some buy-in. And it sounds like, just to put some words in your mouth, that it sounds like also then you had some metrics that you were able to show them a return on investment down the line, which helps sustain the program over time. It looks like we just got a couple minutes left. Does anyone have a last minute burning question you'd like to ask? I will say one question that came through in the registration from a few different folks was asking about any strategies you tried that failed that you learned from. Is there anything that sort of a last thought about something that didn't work, but then you were able to turn that into, a success?
I'm not sure if it's a failure, but trying to get the physicians to transition at the proper time is a challenge for me. People don't want to let go of their patients. So I struggle with that. So we do, as everybody else does, 2 years off treatment and disease-free. Some people think it should be 3. Some people think 5. Or, this patient has something that I'm just watching, but we can watch 2. And they sort of forget that. But we did sort of put in our Epic system a follow-up actually transition to survivorship, which has helped a little bit. And then I sort of just kind of keep track of the patients and stuff when they're due to end. And my other nurse practitioners who do more of the active patients, I have them on board so they keep track of their patients when they're getting close. And we just developed a new flyer, a brochure that we have them hand out earlier than we were, which is helping with the transition.
Yeah, I was actually, it was something very similar. I mean, in the beginning, I thought everyone was going to be dying to refer to late effects. And our oncologists are very connected to their patients. So we do a shared care model where I actually do late effects care, but if they have any oncological needs, including surveillance scans and things like that, they're still seen by their primary oncologist. And that kind of helped everybody ease into it. And then now I'll have a lot of oncologists who are like, oh my gosh, you're 5 years off, please see them. And I don't want to see them again because I have too many other things to do. And so I think it was a work in progress. But I remember thinking I was going to have an explosion of new patients, and I didn't right away. And I think that was a big learning moment for me.
I have to agree. That is such a key point for both patients and providers to know that we're complementing or having shared care so many times. Even some of our recommendations for our brand new patients who are maybe out from the adult side, who are just meeting us for the first time, they'll say, can I just run that recommendation by my, can I just talk to my, my hematologist who I've known for, 5 or more years? And of course, yes, please. So I think the more that everyone knows that we're really sharing the care for that patient and complementing each other, I think that's incredibly helpful. And I think along those lines, periodically meeting with people who may not, or providers who may not be as familiar with the program on a regular basis, and just reminding them of the program and updates to the program is helpful in keeping them engaged.
Thank you, everyone. This was a really excellent session. I'm really, I learned so much from all of you. Thank you to Children's Cancer Cause for hosting. Please see the resources in the chat. There's lots of great links there. And Julie, I'll turn it over to you to close us up.
Thanks, Katie. I just want to echo what she said and thank all our wonderful speakers and all of you for showing up. We really appreciate it. And we, as everyone has said, we do want to encourage people to look at the resources that Charlesley has posted in the chat and reach out to these programs who have been recognized for the work that they do, recognized by Children's Cancer Cause for the work that they do, because we really, they're programs of all sizes and different geography and all that kind of stuff, and have different expertise or specialties that they have. And we really encourage you to reach out to them one-on-one and ask them questions. So we collected this information for that purpose, and we will continue to add to that. So we really encourage you to use that as you need to. But thank you all again for coming. We really appreciate your time and hope you found it helpful.
And Megan, good luck with your medical career.
Thank you.
Thanks,
Bye.
everybody. Bye-bye.